Hello, this is Dr. Tom Charlton, co-chair of the Academy of Medicine of Cincinnati's Protocol Committee. This module is an added training for the 2026 protocols intended for use by departments that are starting buprenorphine field administration programs. I want to thank Dr. Jordan Singer, an EMS physician from University Hospitals in Cleveland, for his permission to use portions of his own buprenorphine training module. The buprenorphine program we will discuss today is based on the California Bridge program, started several years ago by the state of California. This model is widely accepted and has significant research backing its safe use. It also will serve as the state of Ohio's groundwork for our own statewide white paper. I do not have any disclosures. At the end of today's training, you should be trained on the pathophysiology of opioid use. You should understand the stigma associated with substance use disorder. You will understand the new opioid withdrawal protocol, be able to successfully apply the COWS score, and understand your agency's referral process for outpatient treatment. The human body has distinct opioid receptors with differing functions. The human body produces its own endogenous opioids. However, we can also administer exogenous opioids that will bind to these receptors. The most common receptor is the mu opioid receptor. When triggered, it provides pain relief, causes euphoria, and has sedative properties. In medicine, we frequently use compounds that bind to this receptor to control pain, and occasionally we'll use it in combination with other medications to sedate patients for procedures. As more of the mu receptors are bound, the effects strengthen, which can lead to CNS depression. The patient will then slip into unconsciousness and sometimes will have respiratory depression or respiratory arrest. It is primarily the respiratory depression or arrest that kills patients in an acute overdose situation. Luckily, we have other compounds that antagonize the opioid receptors as well. Naloxone, or Narcan, is the most commonly used of these medications. Naloxone binds to the mu receptors, causing the opioid to detach. As the naloxone binds to more receptors, the opioid effects lessen. The patient begins to ventilate more normally, causing carbon dioxide levels to decrease and improving the patient's CNS status. When we encounter an acute opioid overdose, it is important to remember that the patient's breathing and airway should take priority over naloxone administration. Naloxone does not have immediate effects, however, temporizing things with bag valve mask ventilation and simple airway maneuvers can improve things within seconds. When encountering the unconscious patient, opioid overdose is among the differential diagnosis. Start by providing respirations, support the airway, and administer naloxone. Sometimes additional naloxone is required. When determining how much naloxone to provide the patient, it is important to take into account how much may have been administered prior to our arrival. Naloxone is widely available to the lay public and our law enforcement colleagues. To appropriately administer naloxone, we must understand the kinetics of the medication. Today, many patients will receive naloxone via the intranasal route. This route is widely available, but takes approximately 8 to 13 minutes for effectiveness. Dosing before the medication has been allowed to work does not speed up the process. Give the medication time to work before administering more. Naloxone has its peak effect for approximately 2 hours. Several retrospective studies have demonstrated that the risk of having respiratory depression requiring additional Narcan after the original Narcan is metabolized is low to zero. However, we still need to attempt to transport these patients for monitoring, connection to treatment, and treatment of other comorbid conditions. When giving naloxone, there are two complications that we must be aware of. Pulmonary edema can occur following administration. However, it is not known whether this is the naloxone itself or the opioid overdose as the cause. The treatment is positive pressure ventilation. Naloxone, especially when administered at higher doses, may precipitate withdrawal. This is more common in those dependent on opioids as opposed to casual use. The goal when administering naloxone is to improve the patient's ventilation. We should not aim to wake the patient up, as this increases the risk of precipitated withdrawal. As long as the patient is breathing adequately and protecting their airway, Additional naloxone should not be administered. A common misconception is that we should give enough naloxone to wake the patient up. This is not true, and again, raises the risk of precipitated withdrawal. Precipitated withdrawal has an entirely new set of concerns and should be avoided. To summarize the treatment of opioid overdose, airway and breathing are our number one priority. Nasal and tidal capnography can help guide our ventilations with a goal of 35 to 45. Once the airway and breathing are controlled, naloxone should be administered. Our protocol calls for 0.4 to 4 milligrams via all normal routes, such as intranasal, intramuscular, intravenous, or via IO. A reminder that EMTs are only permitted to administer naloxone via the intranasal route or to use a preloaded automatic device intramuscularly. The maximum dose total is 10 milligrams. If the patient has not responded to the naloxone by that time, there may be other conditions at play. You should use the lowest dose required to stabilize their ventilations and airway. A frequent concern is how to handle the cardiac arrest encountered during a suspected opioid overdose. These cardiac arrests should be managed as normal. Naloxone is not going to cause the arrested patient to begin breathing or regain pulses. No studies have demonstrated improved outcomes from naloxone administered in an arrest. Now that we know how to treat the opioid overdose, we need to discuss opioid use disorder. This is characterized as a patient using opioids in a dangerous way or exhibiting two of the following: ingestion of opioids in larger amounts over longer periods of time than intended, desire to cut down on use, significant time spent trying to obtain opioids, craving opioids, opioid use that interferes with home, school, or work, continued use despite negative consequences, tolerance to opioids, or symptoms of withdrawal when not using. In the United States, approximately 6.6 million people have opioid use disorder. As we are all aware, between 2002 and 2018, the use of, quote, heroin, unquote, doubled. The heroin currently available is commonly adulterated with fentanyl, carfentanil, or xylazine. These compounds are much more potent than pure heroin, also known as diamorphine. As a result, overdoses have increased significantly, as even minor alterations in the makeup of the heroin can have profound potency consequences. Opioid use disorder does not discriminate. It affects all races, all ages, all religions, all communities, regardless of whether wealthy or poor. Opioid use disorder has long-term health consequences. Patients using the intravenous route have significant risk of developing endocarditis, spine infections, blood infections such as HIV and hepatitis, and serious skin and soft tissue infections. Some of these conditions can lead to death. There are also other negative consequences, such as increased exposure to violence, prostitution, homelessness, and poor nutrition. If the consequences of opioid use disorder are so bad, why do people continue to use? As in most medical conditions, our chemistry has a role. In opioid use disorder, our brain chemistry fundamentally changes. This means patients develop tolerance, therefore needing higher doses, and become dependent on opioids to feel, quote, normal. These changes also make patients more susceptible to relapse. Opioid withdrawal is an extremely uncomfortable experience. While withdrawal will not kill the patient, it makes them feel like they will die. Many times, continued opioid use is because of the fear of withdrawal rather than the euphoria it once caused. Many times, these patients may have severe pain comorbidities that led to their substance use disorder. The brain, in an attempt to be, quote, normal, also increases the amount of mu receptors. This leads to tolerance, but also means that patients have their pain thresholds lowered significantly. In other words, they become more sensitive to pain, especially when withdrawing. There are social consequences to opioid use disorder as well. Many times, patients will find themselves surrounded by others with substance use disorder. It is extremely difficult to get sober when everyone around you continues to use. Patients may have to cut ties with all of their friends that continue to use in order to achieve sobriety. Unfortunately, significant stigma has developed around all substance use disorders. Many people believe it is a personal choice to continue to use. As a result, pejorative terms such as addicts or drug users may be used. Substance use disorder is not a character flaw. It is a treatable disease. The goal is achieving sobriety, not getting clean. Because of the stigma, many patients suffering from substance use disorders are embarrassed to have the disease, have had bad interactions with society and medicine, and may be defensive because of these experiences. Showing respect and empathy towards these patients will help establish a rapport, giving us an opportunity to intervene. Treat these patients just as you would treat any other disease. We do not make fun of the heart attack victim because they had one. Opioid use disorder is a chronic medical condition. Their brain chemistry is fundamentally changed, and relapse is a real risk. It is normal for a patient to relapse 3 to 5 times before achieving long-lasting sobriety. Just as with diabetes, opioid use disorder can become uncontrolled until adjustments are made. We are fortunate to have treatments available for opioid use disorder. In order to successfully treat these patients, it is important to know the signs of withdrawal. Patients that use shorter-acting compounds may develop symptoms in a matter of hours. Those using longer-acting compounds may take several days. Nearly all patients will develop withdrawal symptoms in less than 1 week. The symptoms of opioid withdrawal are a result of the various opioid receptors no longer being triggered. This includes lacrimation, rhinorrhea, piloerection, myalgias, diarrhea, nausea and vomiting, dilated pupils, photophobia, insomnia, and autonomic hyperactivity. These symptoms can make the patient feel as if they are dying. Opioid withdrawal itself is not fatal. It can still be dangerous for patients, and at the very least is very uncomfortable. Having compassion for these patients and treating them with dignity during their withdrawal has profound impacts. There are two primary ways that patients suffer from withdrawal: stopping use or having withdrawal precipitated by medications such as naloxone. To better objectify the severity of withdrawal, the Clinical Opioid Withdrawal Scale, or COWS, was developed. The COWS score has 5 levels within it: no active withdrawal, mild, moderate, moderately severe, and severe. The score is based on measurements in multiple categories, which we will get into shortly. The treatment of opioid withdrawal ranges widely. Prior to the advent of better treatment programs, we used to simply treat the individual symptoms causing distress. Patients with diarrhea were put on loperamide. Those with nausea and vomiting were given ondansetron. Agitated patients were started on clonidine. None of these combinations was very effective and could only be used during the withdrawal phase. Modern treatment is focused on both preventing withdrawal symptoms and harm reduction. Buprenorphine is an opioid compound that only partially activates the mu receptors. However, it has a very strong affinity for binding. This means that it can displace existing opioids, but does so without significant risk. It has a ceiling effect that limits respiratory depression and limits euphoric effects. It increases safety for the patient, as even if they relapse and use while on buprenorphine, the other drugs cannot push the buprenorphine off of the receptor. This means that their body does not respond nearly as strongly and often prevents euphoria and respiratory depression. By binding the mu receptors, buprenorphine prevents withdrawal, reduces cravings, and prevents further opioid overdose. By treating the withdrawal symptoms, we lower one of the barriers to sobriety: fear of withdrawal. Patients supported with buprenorphine are much more likely to maintain sobriety in the long term and have lower overall mortality rates compared to those continuing to use. Because buprenorphine reduces cravings, it also means that patients are less likely to relapse. As previously stated, buprenorphine binds so strongly to the mu receptor that most other opioids are unable to push the medication off. The receptors are saturated and bound, meaning other opioids cannot fully agonize or trigger the receptor, which would lead to potential overdose. The highest risk to a patient for overdose is during a relapse. The patient may have previously been using a given dose. Their body does not have the same tolerance as before, so what previously was a quote safe dose for them may lead to overdose. By having buprenorphine present, we can prevent the positive feelings associated with use and at the same time block the deleterious effects. Buprenorphine is available in several formulations. For outpatient treatment, tablets, oral films, or orally dissolving tablets are frequently used. Many times, the buprenorphine will be combined with naloxone. This prevents overdose if a patient melts or dissolves the tablet into liquid and attempts to inject it. The naloxone is not able to be absorbed by the intestine, so when taken orally, it has no effect. However, when injected, it is able to get into the bloodstream with the buprenorphine, preventing overdose. Until recently, there were significant regulatory hurdles to initiating someone on medication-assisted therapy. Patients often had to go to a clinic or hospital for treatment. This is a barrier to many patients secondary to transportation issues, privacy concerns, and work-life interference. The use of buprenorphine is strongly associated with reduced deaths from opioid use. EMS is uniquely positioned to interact with opioid use disorder patients, intervene to prevent further harm, and connect patients with outpatient treatment. Patients who overdose have a 10% one-year mortality risk. This is likely the highest mortality of any of our patients that commonly refuse transportation. These patients often have had multiple negative interactions with law enforcement and healthcare. They are often reluctant to be transported as a result. EMS may be their only contact with the healthcare system, and thus may be our only opportunity to help. Once a patient overdoses, they are far more likely to overdose in the future. Multiple EMS agencies around the country began administering buprenorphine in the last decade. One of the first programs was in Camden, New Jersey. The state of California has one of the most widely used programs called Bridge. Many pre-hospital protocols required involvement of medical control prior to giving buprenorphine. Ours does not require medical control, as California's program has demonstrated significant safety with this approach. Our opioid withdrawal guideline is for use by advanced EMTs and paramedics only. It is important to know your state's scope of practice. Buprenorphine is not within the scope of practice for EMTs. We start with screening for withdrawal signs. The patient must have two or more of yawning, runny nose, watery eyes, dilated pupils, tachycardia, sweating, restlessness, agitation, vomiting, diarrhea, or goosebumps. If the patient has two or more, we move to the exclusion criteria. We cannot use this guideline if the patient does not have signs of opioid withdrawal or is less than 16 years of age. If the patient has used methadone in the last 10 days, buprenorphine can precipitate severe withdrawal and therefore precludes its use. Patients that have a severe medical illness, such as sepsis or respiratory distress, should not be started on buprenorphine. Lastly, patients with altered mental status or those unable to give consent for treatment or lacking capacity should not be started. Methadone is a long-acting opioid. As a result, even if the patient has an elevated COWS score indicating active withdrawal, buprenorphine administration will potentially make these symptoms worse. Any use within the previous 10 days can be associated with it. However, the highest risk is in the first 48 hours following their last dose. Altered patients do not have the capacity to understand the risks and benefits of starting this treatment. These patients should be transported to the emergency department where we can discuss treatment when appropriate. Now that we have screened the patient, we need to apply the COWS score to them. Luckily, the score is already built into ESO and other ePCR platforms, However, it may need to be turned on in the administrative settings. Our guideline requires a COWS score of greater than or equal to 8. Patients with a score less than 5 are not in withdrawal. Giving these patients buprenorphine will precipitate withdrawal. As the COWS score increases, the likelihood of precipitated withdrawal decreases. If you are unsure about someone's score or eligibility for treatment, contact medical control. The COWS score is based on several categories: resting heart rate, sweating, restlessness, pupil size, bone or joint aches, runny nose or eye tearing, GI upset, tremor, yawning, anxiety or irritability, and lastly, goosebumps. Establish your COWS score. Do not forget that a COWS of less than 5 means they are not in withdrawal, and we do not want to cause precipitated withdrawal. If they are not in withdrawal, it is likely that a fully agonizing compound is on their mu receptor. If we replace that fully agonizing compound with buprenorphine, only a partially agonizing compound, the different degree of effect will be experienced by the patient as withdrawal. Once we have established that the patient is a candidate for buprenorphine administration, we need to have a conversation with the patient. It is important to be empathetic with the patient when presenting the various treatment options. Treatment options include transporting to the hospital, providing a leave behind naloxone kit, starting buprenorphine, referral to outpatient treatment, or any combination of the above. Of course, patients may refuse treatment and transportation. Patients should understand that the dose of buprenorphine we give to them will last 24 to 36 hours, keeping withdrawal symptoms away and preventing another overdose. The risk of precipitating withdrawal, when the guideline is applied correctly, is low. If it occurs, the patient should know that we can treat this precipitated withdrawal with additional buprenorphine. If the patient consents to treatment, the initial dose is 16 milligrams sublingually. Each agency may choose a different formulation. If using a tablet form, the dose remains 16 milligrams. Reassess your patient with another COWS score in 10 minutes. If their symptoms are worsened or persist, administer another 8 milligrams. If their symptoms have improved, obtain good demographics on the patient, provide leave behind naloxone if available, provide outpatient referral documents if available, and repeat your COWS score. We should try to encourage transportation to the emergency department, as the hospital can help connect them with treatment and develop a plan. If the patient does not want transportation, we may obtain a refusal despite the buprenorphine administration. A common question is, why should EMS start buprenorphine when the hospital can? The answer is simple. Many of these patients refuse transportation to the hospital, and so the window of opportunity to intervene may begin and end with EMS. EMS is uniquely positioned for rapid treatment. Patients will receive their buprenorphine much more quickly with us than in the emergency department. Just as we would not withhold morphine from a femur fracture patient, we should not withhold buprenorphine for opioid withdrawal. Patients may choose to refuse transportation. This is their right as long as they meet the guidelines. The patient can be treated with buprenorphine and still refuse. If the patient is higher risk, or if you have questions, involve medical control for guidance. Some agencies offer mobile integrated healthcare services or crisis teams. It is important that we obtain as much demographic information, including cell phone numbers, as possible to facilitate follow-up. The patient needs to be connected with an outpatient treatment provider. The referral process may vary based on local resources. Each agency should work with their resources to develop a handout listing different facilities. At the very least, the Substance Abuse and Mental Health Administration has a website with referral options: findtreatment.gov. That concludes the training on the new opioid withdrawal guideline. Please review the document itself to familiarize yourself. If you have questions or concerns, please follow your normal chain of command and/or discuss with your medical director. Thank you.